Hey everybody, welcome back to Prehospital Paradigm Podcast. I'm Scott Wildenheim. Got all of our new crew here and our old crew here as well. So no Caleb today, and as we kind of spoke about on some previous episodes, we've got AJ and Wes Green that are joining us in lieu of Ray, who's doing his chiefly duties, and he's going to pop in occasionally, but we've got the ad and the two of you, so each of you, I think, have done an episode or two before. I think it's the first time you guys have been on camera together, though.
That's
so,
right, correct. First time together.
This is awesome.
Yeah.
So got half of the new crew and then half of the old crew, and Dr. John Hill across from me there. So, hey, so actually Wes had this great idea, and obviously this entire thing is put on, this whole podcast series and whatnot, put on by university hospitals and our EMS Institute, and we talk about that like everybody understands that, right?
Mm-hmm.
It's like it's this product that the rest of the world should immediately understand. So for this special series, the fifth Mondays of 2026, we're going to kind of do some self-touting here. We'll do a little bit. We're going to talk about the EMS Institute and all of its disparate things. We touch so many different things. It's not just a hospital medical control. That's probably what most of the end users see most days and what they're most intimately familiar with. But there is a whole background that really it just happens for them. They don't see, and a lot of people don't know or have much appreciation for what goes on in the background and how we get some of the things to them and out in the world that honestly are kind of taken for granted in this region. Not saying that all of these things we get right every single day, but there's these are the things we strive for, and then the products, what we have in our we have teed up and try to get out to help the populace at large.
Yeah.
So, there's things that even me being with the Institute for the last almost 5 years.
5 years, yeah.
There's some things that I don't even know that we do. I'll say that there's probably things at this table you guys don't even know that I do, even behind the scenes.
Yeah.
So,
100%.
No, there was just today I was informed that we do some sort of safe cities thing up in Ashtabula County. I had no idea that we had sourced the grant money, and it's basically running on autopilot, and I actually don't know where it goes. Again, it was brand new information to me.
Yeah.
But out of Geneva and out of Conneaut, apparently we sponsor this, some sort of safety initiative in the community. I didn't even know. It's we applied for the grant money. We shovel it out to the however that helps the community. I had no idea this was going on. Right? It's exactly John was talking about. Is there's so many other things, and we're deeply involved. We're deeply involved every single day of the week. So I guess I'll start with kind of an overview of what our system looks like. So. I think everybody has figured out that there is a university hospital, and as we affectionately call it, the mothership, right? And that's our level 1 trauma center and our comprehensive stroke center, and that's located in downtown Cleveland. And then there's this whole other array of community hospitals that, for the most part, it's a hub and spoke model with UH Medical Center down in Cleveland being the hub, and then we've got all of these other community care centers that all which are, I think, for most of these communities, some are critical access and others are generally very well equipped facilities. So let's run this down. Let's see. Your list here appears. I'll say. Oh no, it's not in alphabetical order. This is how it popped out of your head order. Got it.
Yes. It was actually a website.
Oh
yes.
It was what AI generated.
That's right.
Got it. So yeah, let's talk about. I guess we'll start with Ahuja in Beechwood, and that's. I'll say mainly a full-service hospital, right? And they do not have a.
They do STEMIs. They do strokes. They are not a trauma center. Yep. We've got 2 three med directors that work out of Ahuja. Yep. So Dr. Spanner, Dr. Dare, and Dr. Carpentero work out of Ahuja. So yeah,
that's kind of Cleveland's southeast side, right, and where Beechwood is, right?
Here's
Kind
just
of
OB center too, correct?
Yeah,
they're
they
OB.
have OB, yep.
Yep.
In that 271 corridor there, going way out, almost to Pennsylvania, way out. In the 90 corridor is Conneaut Medical Center, and Conneaut Medical Center is a much smaller hospital, critical access hospital. I'm not putting my critical care transport hat on and whatnot. We bring a lot of people from Conneaut. We'll talk about Geneva here in a minute. Same deal. We bring those in, not always to the mothership, if you will. Often to some of the community hospitals where they have more services. It's that hub and spoke. Sometimes you stop at other spokes that have more appropriate facilities for whatever the patient's condition is. Then we have the whole Lake Health system, which I see you've just kind of listed as one here, but it's actually two hospitals. Yep. Yeah. So Lake Health is Tri-Point and Lake West, recently became a trauma center.
Mm-hmm. And it's actually becoming the east side trauma. They're trying to move a lot of trauma actually to theirs being the east side trauma center.
Trauma hub.
Yeah, trauma hub. So they're hired trauma surgeons there. They've got APPs. I think they're trying to offload some of the traumas that don't necessarily need all of the tertiary care that CMC provides to need a higher level of care, all but not necessary. Yeah. So that's Lake is becoming that model for this for the east side.
Yep, and they do STEMI and stroke there. And then we were talking about Tri-Point, and they're located in Concord Township, kind of in the middle eastern part of Lake County. They have some OB services there, but they say they don't do STEMI. They are a primary stroke center. So that's our Lake Health contingent. So that's two hospitals there. We've already talked about Ahuja and Conneaut. So that's the kind of the first four there. Then there's this place, which at least two people at this table are qualified to speak to. So why don't we talk a little bit about what's the Portage Hospital, where it's at, and what do they do?
So Portage is in the middle of Portage County in Ravenna. We are a level 3 trauma center. We are a primary stroke center. We are a STEMI center. We no longer have OB. OB left us a few years ago. It got consolidated up into Ahuja. Just because we weren't birthing that many babies at that place. And so if you're into OB and prenatal care, there's a lot of risks actually that happens if you're not birthing babies every day. And typically you want to be something like they want you birthing multiple times a day, and if you drop below essentially 2 births a day, you kind of lose
your status.
Yeah, you're just not as good at it because you don't do it as much.
Of course.
So that's kind of what happened to Portage is moved OB out of that and moved it to a better center that
consolidates.
Yeah.
And keep their volume up also.
Yeah, exactly.
Yeah.
Yep.
In a location that also needed OB services.
Correct.
That was,
Yeah.
And one of the things that goes along with OB services is NICU status. Correct. And understanding like you have to have pediatrics there OB is just mom was mom. Mom has vessel for a baby, and once a baby comes out, OB has to hand off to pediatric specialists.
Neonatologists. Yeah. And then we've got at least one person here that is qualified to talk about UH Samaritan.
Right. That is far south.
It is far
It
south.
is all the way south.
Yeah.
So, and then they are primary stroke. That's really the only thing they do there. They do have PCI during the day, but it's not for emergencies.
Yeah.
They're not 24/7, so squads don't go there. Yeah. It's just is scheduled. So they no longer have OB services either. Same reason, just a volume issue.
Moved up to.
Yep.
Which becomes an issue for rural people, actually, right? There's a huge transport time, and from a med director standpoint, like how do we manage these people that, and I'm the same way, my wife we didn't take her to the hospital until she was going to deliver.
Yeah.
but maybe they call too late and they're a multip, and now you're going to be delivering a baby in the back of the ambulance because you have an hour and a half transport time.
Right.
Yeah.
It does impact how we provide care in the pre-hospital space.
It does. There's 2 non-UH facilities that have OB services near there.
Yeah.
And the squads have been very good about going to those
Making sure that,
facilities.
yeah.
Yes. But again, on those emergent ones, there's a large Amish population down there too. So Samaritan has to deal with some of that really sick OB patients that, there is no other choice. You have to go to the closest hospital.
Yep.
So
And Samaritan is in
Ashland County. Yep.
Ashland County,
Yep.
and
Ashland City. Yep.
Ashland City. So and it's all the way down 71. If anybody's looking at a map of Ohio, you will notice a 1 hour gap
Yes,
between
exactly.
nearly all of our facilities. I don't know how that.
Well, and our med command from there actually covers Ashland County, Wayne County, Richland County, and even parts of Crawford County.
That's
so
we were going
it's
to talk
from
about
that Samaritan. We'll talk about that more later, but it's from that Samaritan hospital. It extends out to multiple counties.
And I mean, if we're already kind of on the topic.
Portage is the same way.
Let's say tell us how far south Portage goes.
Yeah,
with
so we're
some of
covering Portage is covering Portage County, Trimble County, some of Trimble County, Mahoney County, Columbiana County, Harrison County, and we actually just took on another department in Jefferson County. So we're as far south now as Jefferson County.
we do also parts. We peak a little bit into Stark County as well.
Who's
and Carroll County.
What city is even in Jefferson County?
It's a small department, it's Irondale Fire Department.
But I don't even know what city is in.
I don't even.
In Jefferson.
I don't know. Yeah, I don't know.
I'm picturing a map in my head, and apparently. I'm really dumb when it comes everything south of 80 in Ohio. Yes, exactly.
Yeah.
My county knowledge in Ohio is waning. So we've got
not Wayne County.
No, that's different.
Yeah,
that's Worcester.
So Samaritan, like we said, is in
Steubenville.
Steubenville.
Okay.
Okay. That's a reference for me. All right.
There we go.
I knew there was something down there.
There is something. We talked about Cleveland Medical Center, which of course is that's our everything. That's our everything. And then we're one hospital with kind of 2 personalities in Rainbow Babies and Children's.
Correct, that is true.
Which is technically on the books a separate hospital, right? But it's all run under the UH, run under the UH umbrella. So
I think it's worth mentioning though, even at CMC, we call it Cleveland Medical Center. That does incorporate Cleveland Medical Center and Rainbows. You could also break down the Cleveland Medical Center into different hospitals. Like there's McDonald House, which is the women's health. I'm going to blank on all the other ones, but there are subdivisions and even
within that. Right. Yep. Transparent to the patient
care.
Correct.
Yeah. There's Seidman Hospital inside of that, which is our cancer center.
So we've talked. So we've got down there. We've got pediatric trauma, pediatric level 1. We've got, of course, all the high risk neonatal and all that is downtown as well. All of the super sick stuff is down. Right. That's our ECMO center. We're doing ECMO CPR in the ED down there, and then ECMO they've got somebody on pump at any given time in the ICUs, right? What other populations are we forgetting that are up there? Again, it's our catch-all. It's where all of our specialists are.
It's our tertiary care center.
It's our tertiary care center, exactly. All of our surgeons, all of our cardiac.
But all these other hospitals gain from that, of having that, either even from education or services, or obviously the transfer is there for all these.
Or consults. For me in the emergency department, I can call up and get a specialist on the phone within minutes to help me diagnose and treat a patient, and then ultimately what's going to probably end up happening is that patient then gets transferred to CMC, but I get their help in the emergency department to help initiate care in the emergency department, and then call critical care more likely if I'm doing that to then transport them up there.
And then also
next one's back to me too.
About to say also qualified to answer the Elyria question. Tell us.
So that's Lorraine County. Again, it is in the city of Elyria. It is again stroke, STEMI, level 3 trauma. And just recently, the end of last year. Only one in Lorraine County. The only trauma center in Lorraine County now. So that trauma volume has probably
slightly busy.
yes,
That's
yes,
right.
it's increased.
You guys surpassed Portage as the
Yes,
busiest
level
trauma
3
center.
trauma center.
Yeah.
and then we just recently started ECMO
Oh, and
CPR
yeah,
out there. So,
yeah.
and again, that is tied in to directly to Cleveland. That's a process that starts immediately from the pre-hospital call. That the transfer center, everybody's notified, critical care is notified, perfusionist is notified, and there they do the cannulation a little differently. They do it in the cath lab. So the cardiac intensivists are doing the actual ECMO cannulation, which then leads right to usually a regular PCI procedure also. So
While you're here,
right,
let's take
exactly.
let's take
So
a peek.
exactly.
Yeah.
So we got you on pump, we got your flow back up, and then they'll do the which is usually what we're hoping with the age population and presenting in a V50.
Which it makes sense, right?
It does.
Like,
It does.
just
So,
intervene when you can intervene. Yep. And then transfer.
which again has been a big deal because
I wanted to
the
emphasize
community. This is a community hospital,
yeah.
that's doing this procedure. So we had a recent one that one of our other guests here, Dr. Singer, was actually part of. So completely walked out, neurologically intact. Was just back at Elyria recently,
Yep.
For a visit. So
And we had Dr. Ford and Dr. McCluskey on talking about the whole concept of eCPR, and then subsequently, Elyria has come online, and I want to point out what a big deal
it is
out in the community.
And I will give shout out to Dr. McCluskey because the support and everything that we've gotten from ECMO downtown at Cleveland has been amazing.
Yeah.
Like just the work they've actually shared, the knowledge they've shared, and everything else to get the program running. So, but for a community hospital, it's a big deal. There's lots of moving parts.
There is.
Yeah.
That the institute is involved in lots of that, from our quarterback, which we'll talk about later, to EMS education, to transfer center, to transfer quarterback, to CCT. All those parts are activated pre-hospitally, and it needs to happen that way. So those parts are already moving before cannulation, before arrival, even at the ED. So it's definitely interesting.
Yep, and that is ultimately kind of the vision of that whole ECMO group downtown is to have the busier community hospitals being ECMO receiving centers, if you will, right? So there's transport options for our pre-hospital providers to get these patients on pump sooner and change outcomes, right? On patients that otherwise we would be throwing standard ACLS at for extended periods of time, only to go, sorry, it's not working, nothing we can do.
Yeah.
Also, something we have in Elyria is when the laws changed around initiating blood transfusions in the field, we initiated
Great point.
Dr. Singer to allow for the SWAT teams to go pick up blood at Elyria and have it on site for initiation. So not doing what Cleveland EMS is doing with blood, but we have it available under special circumstances, the high-risk circumstances. That's something else that we do is we provide blood to patients that need it in the field.
That in of itself is a very, very deep topic, and we've had no less than 2 episodes of that delved heavily into scope of practice changes and what blood administration looks like in Ohio and in this region, right? Because as we continually talk about, this is kind of the way it works in this region. We know it's different in many other places in the States and
this system there, the Elyria is developed as a zero waste, so it does go out on those high-risk calls that have a high risk for obviously needing it, and then it's coming back either in the patient or in the cooler, and it's a very high-tech cooler system that's Bluetooth and everything's documented, so there's no loss of blood, because that's a big worry in any pre-hospital blood program is any kind of waste. So.
Correct.
Well, and if you think about cost of blood, is that unit of blood is potentially costs as much as the whole drug box that we hand out to people for prenatal care. So if you treat blood as a drug, it is the most expensive drug that we carry and administer.
Yeah.
And we talk about Geauga, another here right in Geauga County, right up the road from where we're filming this. So we're in a auxiliary UH facility right down the road from UH Geauga. Level 3 trauma center, again PCI center. Do STEMI. Very well oiled machine STEMI between Portage and Geauga. Not that the other ones are not, but the guys that run those have been doing it in that space for a long time, and they're very, 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 very settled in.
And that's Dr. Stefano's home hospital. That's
Correct.
where he works out of his yoga and does a fantastic job from STEMIs.
Yep. And then who's been on multiple times. Actually, most recently with our episodes, our cardiac episodes, CardioCast, our 5th Mondays last year. He rounded out the year with some actual cases and some imagery that he brought from real cases. It was very, very nice. Then we've got in southwestern greater Cleveland area, near kind of the near-ish west side, when we're looking at this geography anyway, is Parma Hospital. And Parma is also a very busy hospital.
Correct.
Yeah, that's
their level 3 trauma center.
Yeah.
Stroke and STEMIs.
STEMI, yep. That's another very busy place. Probably one I would imagine that's going to be next on the ECMO list, or that or Portage would probably be the two I would imagine.
And that was their discussion of Leary is a test site for the community hospital ECMO.
Community ECMO.
Yeah.
If we get all those parts working,
That's the model.
If we can, and that's really why they went to Elyria first is, we're downtown. Okay, so, in our by protocol, we got a 30-minute transport. So Elyria is the farthest west we can go. So you're getting a true 30-minute population adjustment, So if we can keep moving those circles, those 30-minute circles
yeah.
around, then, all these people are going to end up downtown, for, the ICU. But it's, if we can keep moving that, then we're extending services to people that would not have those services.
Yeah.
So.
Chances of life.
Well, an ECMO CPR is one of the, and I said this before when we talked about it. It's one of those. It's one of those new frontiers that we're starting to expand into from medicine. And it's probably going to make a huge difference in people's outcomes. Blood's obviously on that list.
Yep.
But ECMO CPR is definitely there because we've seen really good outcomes. Correct. And honestly, CPR, surviving a cardiac arrest you don't have a high probability of surviving.
I think it's 10%.
Yeah.
Regular ACLS is about, and ECMO alone takes you up to at least 30.
Yeah.
And CMCs has even been better than that.
Correct.
So, but still 20% extra.
Yeah. I'll take that.
Absolutely. Yeah. I mean,
then in Westlake, again, a western suburb.
far west,
Yep. Not quite as far west as Elyria,
nope,
but it
nope,
is.
But it's the next.
Yeah.
It's the next one.
No.
So
It would be the first kind of stepping stone out of Cleveland, downtown Cleveland, if you will. And St. John's, again, very
busy.
busy hospital.
Yep.
With Westlake and that whole catchment area there, level 3 trauma center.
Correct.
I think people might be seeing a trend here that we rely heavily on our level 3s. Part of that is baked in the transport services that we'll talk about later. That's how we make that work, right? Is we have our own transport piece baked in to support the needs of these community ECMO, the level 3 trauma centers, et cetera, et cetera.
Well, we'll talk. I was kind of talking about it in our service line section, but the community hospital trauma program, again, which the EMS Institute's highly involved in, it does work. It extends that out to where you can't have level 2, level 1 in all these places. So having that out there, we had a experience at Elyria the same way where the trauma surgeon, they brought him in Elyria. Critical flight was en route.
Yeah.
They crashed in the ER.
Yeah.
She went right to surgery.
Yep.
Closed him up, gave him blood, and then we flew. And it worked having that service out there. They probably would have passed away
100%
in the helicopter on the way, downtown. So that really did. The level 3 system does work, and it's coordinated with, again, we have a whole community hospital trauma program. So it definitely does work having those extensions out into those hospitals.
Yeah.
Let's see what else at St. John's. STEMI and primary stroke. I mean, that's kind of our community hospital model, right?
Yep.
Is level 3 stroke STEMI capabilities. The only ones that really kind of vary from that are Conneaut and Geneva, which isn't on this list. So Another, again, much like Critical Access Hospital in Ashtabula County. And if anybody has ever seen a map of Ashtabula County, it is gigantic. Man, you ever try to drive across it? I feel like they're driving across its own state. It's the Texas. It's the Texas of Ohio's. Counties.
Ohio's not a small state either.
No, it's not.
It still
That's
takes
true.
4 hours from here to get down to Cincinnati.
Yeah.
So we're no slouch either, right?
Well, let's talk about our partners.
Yeah.
And let's talk about the first one near and dear to us. Tell us a little about Western Reserve, John.
So Western Reserve is a partner hospital in Summit County, just north of Akron, sitting in Cuyahoga Falls. Level 3 trauma center. It is a primary stroke center, not a STEMI center. So that's the one thing that we don't do there. Interestingly enough, though, is we're more of a level 3N. We have neurosurgery capabilities there. So we will take a little bit more. We'll take the traumatic head bleeds. We've got a spine surgeon, those types of things that we can take at Western Reserve. So nice little community hospital as a partner to what University Hospitals offers.
And specifically follow the EMS Institute and
Yep.
and our policies, procedures, our model, if you will. So really, from the EMS side of things, it's just an extension. It's another hospital. It's
Correct. Same drug
It's
boxes.
not looked at as a partnership. It's
Exact same protocols, same drug box, same everything, which is kind of nice that, and our protocol follows the regional protocol, slight modifications, but you can hop into any ambulance or be on a mutual aid call, especially if you're all or Western Reserve or Altman or Southwest, all those.
Yeah.
Same drug boxes, same protocol. You guys know every guy and gal can work side by side in the back of ambulance and know how to do things according to the exact same protocol.
Exactly.
And that's a huge help.
It is,
I used to work for a place that wasn't the case. So it was always, I'm bringing my own drug box, or I'm bringing, you know what I mean? Because not everybody worked together.
Correct.
So.
And that same model from the EMS side of things extends into our partnership with Altman. Altman hospitals, boy, what do they have? 3 or 4?
They have at least 3.
They have at least 3. So they've got Canton Altman, which is their air quote mothership, right? Massillon, which I believe is a freestanding ER. They've got their whole own network of hospitals. From the EMS perspective, like we were just talking about with
So we got Alliance,
that's what I was saying.
they're Canton, Massillon, and Oresville.
And Orville.
Yeah, Orville, yep.
Had to check OneDose.
Yeah, it's
There you go.
I think Massillon's a freestanding, or is that I can't remember.
So I know that, so Canton, they're a trauma 2,
Trauma
actually.
2.
Yep. They've got STEMI, they've got OB there, PEDS, and their primary stroke. And then Alliance Hospital, they are tenecteplase only, so they'll accept stroke patients. They can give tenecteplase there, but they don't admit there. They'll then get transferred out.
They'll get transferred. Yeah.
And I think that's probably true for our critical access hospitals up in
That is absolutely true for our critical access hospitals.
for Conneaut and
Geneva. And that rounds us out with.
Well, there's one other partner hospital, Southwest.
Oh, yeah, I forgot.
Oh my goodness, Southwest. Yep. Again, same
Yep.
deal. They're following same protocol, same from the EMS side of things, and I know they do STEMI. I'm blanking on their trauma.
They are a trauma center.
I think they're trauma 3. When I was a young lad,
Yep.
they were a trauma 2.
They're trauma level 3. They have OB,
OB.
STEMI, and primary stroke.
Wes, have you spent any time out at Firelands?
A little bit. That's more of a. There's just some services that we provide UH provides to back up on
support.
Support. But it's more of a low area for the EMS.
Yeah.
They usually tie into somewhere else. I mean, in the medical director's sphere, but it's more of an area than necessarily the Firelands Hospital.
We're doing more with the agents, the EMS agencies, than we are the hospital proper.
But we do have some. I think HHVI definitely. I think has the support.
They're trauma 3,
Yeah.
primary stroke, STEMI, and they do obstetrics as well.
And we've progressed even further west.
Yeah.
Again, not with even hospital base, just with EMS agencies.
Just with the EMS agencies, right?
Yep.
That are just looking for repeatable,
Correct.
Consistent medical control. That
Well, that's one reason I came up with this idea was, you go out and talk to these agencies, and you start talking about everything we do, and then you realize, like, we do a lot of stuff.
we do a lot of stuff.
Then again, it is repeatable, and so that's definitely nice.
Well, and our whole system is built upon all the mistakes or errors that we've made before this, right? And there's often times where I come across a problem and I'll ask Scott, because you've been here the longest for me, like, why are we doing what we do now? Like, oh, there's this happened.
Yeah.
So because someone made an error, a mistake was made, we tripped or we stumbled, we've made a change in how this is what we do.
Mm-hmm. Yeah.
When I talk about that other places where, especially like even Samaritan, where we gain from all those other EMS agencies, that mistakes or corrections or, even a study or whatever, but that passes down to everybody.
Yeah.
Gain from the collective,
Yeah,
No, 100%.
Yeah.
That's really what an EMS system should be striving for.
Yeah, don't wait till my department does it.
Yeah.
Oh, we already had that problem. We can prevent that from happening multiple times.
Yeah.
So.
All right, so we have thrown around the term at this table, probably with little definition outside of anybody that's, again, in that UH sphere of influence that knows kind of how we do things, is an ED quarterback. So who wants to talk a little bit about, the concept of the ED quarterback? And
It's an interesting concept.
it is a very interesting concept.
If you transport someone that doesn't have them, you don't know how great it is, actually.
Correct.
So, they got it from a visit to Pennsylvania. Is where they actually kind of the EMS Institute leadership kind of seen it, and they brought the idea back. So the nice thing is we, for EMS wise, on that sphere there, when you call in for your report, you're talking to a paramedic that should have a great knowledge of OneDose and our protocol. So that might be for refusal, or it might be for one of the feudal red box or med orders that we have, because not all the ED attendings know our protocol inside and out. So it's nice to have that communication of, hey, they're calling for this beta blocker because, those things, okay, cool.
Yeah.
You can explain that stuff to them, or again, the refusals or whatever it happens to be.
And I've even had instances where that for medication dosing as well. Like you said,
correct.
The doctors are like, oh, we usually do this weight-based, but in the EMS world, we're not doing that weight-based.
Right.
You know what I mean? So to answer those questions is huge.
It's nice to have that resource right there in the ED. So, and then we have the Institute has direct to our what we call surface lines. So that's our trauma, our trauma programs. HHVI, which is our chest pain, or STEMI kind of, and then neuro for our strokes. Mm-hmm. So, and we meet with them regularly.
Very much so.
Not only on the system global section, but also at each hospital.
Yeah.
I have direct contact with those people, even today. Multiple emails today with some of them.
Yeah.
But any questions they have, or any EMS information they need, whether it's a EPCR but it goes both ways. So we can give them information from the field, but also we push education out to them on things that might change or needs. So having those right there in the ED all the time when you call in, and you want to call STEMI, you want to call stroke alert, you want to call a trauma, you're talking to a person that deals with those service lines on a regular basis. So it speeds up the communication a lot better than if just RN7 answers the phone or whoever. Yeah. It's nice to have someone that truly has an understanding of the wants and needs of those different service lines. So it's nice.
Whose sole job is to answer the phone. You know what I'm saying? They're not busy doing other things.
Yeah. They're the navigator.
Yeah,
that is
exactly.
literally their job, is to be the EMS navigator.
Yeah.
That's exactly.
Yeah.
John.
Well, and they're EMSI employees, right? Correct. So they're within our own institute. Mm-hmm. They're not hospital employees. They're not ED employees. They're in our meetings with us, sitting side to side. AJ is my quarterback at Portage, so I rely on him exquisitely heavily, and we drive around the state together often. So.
Right.
Down to Jefferson County.
But
couple weeks.
Yep. If I can polish a little bit what you were saying about, we have access to all of those. It is that paramedic, that EMS Institute person that's triggering the trauma response, that's triggering the stroke response. they have their hands on the controls. They you know they push the buttons to make the things happen. Whereas to your the point that you were kind of driving at is a lot of other places that's nursing staff who's also doing patient care, or that's the physician who's also trying to do patient care things. It doesn't replace the paramedic, at least in the state of Ohio, can't give medical control orders, but they can act as a pass-through for the doctor. They can help the doctor and the paramedic navigate, to your point, the protocols and the lay of the land, if you will, specifically for a non-EMS physician, right?
Correct.
That's the tough part.
They kind of orchestrate all of the pre-hospital care that happens, both like the team that's transport team that's coming in via EMS, and that could not even be a UH med control ambulance that's coming in. But they're gonna coordinate the ED response, if there's a trauma response, the STEMI response, the stroke response. They're going to talk to our transfer center if it's like a mass casualty and have that interaction with our transfer center. And most of our quarterbacks are on first name basis with those transfer center people or even our transport quarterback.
100%.
And they can start doing auto launches. Oh, I've got likely a head bleed coming in. We're going to auto launch. Okay, well, our quarterback is going to we're going to call a transfer center. We're going to call our transfer quarterback, and we're going to trigger all of the auto launch stuff and kind of offload, just be that extra set of hands and be that integration between EMS coming in, the emergency department, and then all of the services that we rely on in the ED.
Yeah.
And that now we're talking. You just said a term, the transport quarterback. So we kind of use the quarterback, that navigator, that concierge, whatever you want to look at it. We kind of use that term both on the transport side of things, and that's kind of what we affectionately call our dispatchers, if you will. But again, they're empowered to trigger all of these events and move all of these pieces, mostly by protocol, but like we've already mentioned, they've got a whole team of physicians behind them, right? So there's certain criteria where they might, hey, I've got this many calls going on right now. They'll engage the on-call doctor, and then we'll prioritize and shuffle things around to fit the most needs of the most patients. So there's that kind of that concierge approach in the transport and dispatch spot, and then of course at the local level at the ED with receiving incoming pre-hospital care. And like you guys said, that there's always passing information. And then you've also mentioned the what we call the TRC, or the Transfer Referral Center. That's another center that's over here. The transport quarterbacks, the dispatch for the critical care, air and ground, and specialty care resources all lives over here, co-located with the transfer center. Literally sit shoulder to shoulder in the same room. Their body of work is to navigate all of the admissions to the hospital and coordination of care. So, you spoke earlier about you have access to specialists, right? So you've got XYZ patient, I need XYZ services. You're calling into the transfer center, hey, I need help with XYZ thing, and then they're orchestrating and reaching out and getting conference calls, then subsequently potentially arranging for the beds and getting the reservation. Once they're like, yep, the patient needs to move, then that is kind of like past one desk, one desk down, and then the transport thing happens over here in the transport quarterback world. Yeah. So system integration is
correct.
All that to say, system integration is the huge component of making all of this stuff work.
Yeah. And I think it's an interesting concept. Just to kind of segue a little bit, we're seeing the same sort of concept at hospitals outside of our system, where, for example, if there's an MCI, they're sending fire chiefs to be this person to these hospitals. You know what I'm saying? So we have our people, but out east and even down like in Summit County, if they have an MCI down there, they've got fire chiefs going to each hospital, being that liaison to help coordinate, because they don't have that specific person, but they're finding that in these big incidents they need that.
It's necessary.
Person.
Yeah.
Right.
Yeah. It's interesting. So.
LifeNet.
We're a LifeNet house.
Correct. That's how we activate these services is through, again, it's a LifeNet Striker type computer program. But one thing, and it's, again, it is the daily operation, so those quarterbacks are activating daily those service lines. But also, and as the notes say, is just about development. We are getting ready to switch to a new LifeNet Cares. And the EMS Institute's highly involved
very much so.
In that development. And again, when you create something new like the ECMO, CPR Deliria, that's highly reliant on LifeNet as far as notifying perfusionist and transfer quarterback and everything. So that LifeNet system definitely does work well for us. But we are there in the background also of not just pushing a trauma. It's also development and of the actual program itself.
And that's important that, these systems be easy to implement, right? And that's kind of where we lean on LifeNet with these notification process. So it's not like, okay, there's a patient that's a candidate for ECMO, and I got to pull this binder out, and I got to start working these procedures and policies and protocols to get all these people together. It's literally like, click, ECMO page goes out. Everybody is immediately notified that the process starts now.
Yeah.
I'll just let you know from experience, UH has 19 perfusionists. So
and
they all get a text and a page,
and they
so
all call
and
back.
that would, what I mean, that would be impossible to know who's on call today if you were pulling out that binder trying to figure out, and that this happens at the same time that everything else is happening.
Yeah.
So it's definitely an interesting system.
Everybody's aware it's go time.
Yeah.
It is also in that real time. This is a liaison if there is a problem with that. And it could be good, bad, or ugly. I mean, if there's a problem with, a staff member or something that we can fill in right then. And also, if you have wall times, it's nice to be able, we communicate with them.
They manage that,
They manage it and say, hey, this is what's going on, or if it could be equipment issue, anything. It's a real time right then and there. We can handle problems, whether it's good, bad, whatever. So
when it comes to wall time, that's something we actually do. Like if it's really bad, and typically at Portage we don't have bad wall times, but quarterback can also offload that patient if, let's say, the ER is really too busy and that squad needs to go back in service, and there we have agencies that there are different policies across different agencies, and there are certain time limits and we want to get those ambulances back in service because that's where they need to be. We can offload that patient to the quarterback. Quarterback will take care of that patient, and then when a room becomes available, we'll then move them into the room. But importantly, you can get that ambulance back into service in the community.
Yeah.
Especially, let's say that there's a giant fire going on,
right,
and there's literally every fire agency from York County and surrounding counties are at that fire, and we have an ambulance that has transported a patient but needs to get back to that scene.
Right.
Yeah.
Even from the interpersonal perspective of the the paramedics and the EMTs that are transporting, you get to know it's the same person, right? It's not whoever's assigned to that job today.
And it builds that relationship.
100%.
It does. Yeah, it does.
It's like, hey, Jay, what do you got? Or hey, Wes.
And that's when I answer when I'm working in Elyria, and I answer it. That's
usually
Elyria, this is Wes. Hey, this is Joe. This is John.
And it makes a difference.
It does.
Helps out a
It
well.
does.
Same
It
thing
really
when I'm
does.
answering the phone.
Yeah.
Oh, it's AJ. Okay.
Yep.
Well, you know what I mean? It just helps out. And when they need something too, they know to go to.
Right.
So.
The liaison, and then the next step up is the I guess if we're working backwards towards the physician, right? We've got that front line asset in the quarterback, if you will, and then our EMS coordinator,
right?
Our coordinators and our managers. I'll kind of use them.
Yeah.
In a similar, there's differences in the way we utilize them, but from the perspective of the outside world, it's they're the decision makers at the local, the EMS decision makers at the local level, right? So the transport or the ED quarterback helps with all the navigation, is collect and aggregate
Right now, daily.
Collect and aggregate stuff, and then it's those managers and EMS coordinators that will go out and interact with the fire chiefs and the command staff, and here's broader brushstroke issues and kind of bigger, not, hey, which bed do
Yeah.
which bed do I put this patient in, or how can we?
Or this
turn
change
this
is coming
one call.
down from because we're making a protocol change, and
Yeah.
you're this, or hey, we're going to be short on. Right now, we're dealing with a lot of drug shortage. This drug shortage is coming. This is how we're gonna. They're doing it that managerial aspect of. These are the things that are happening inside the hospital system that are going to be affecting how you care for your patients.
Yeah.
Well, AJ and I both have dealt with problems this morning, of the global nature of that affects all the hospitals. And not necessarily this call you're on today, but, we got some remodeling at Elyria. So we were able to push that out to everybody today. So, or those different kind of things where it's more of a global department. And it might be communication between the department or the hospital or something's changed, whatever it happens to be.
Mm-hmm.
Yeah, I mean that same work that's being done at Elyria right now, again, that was managed backwards to our helicopter needs, because there's an auxiliary pad now
Correct.
that gets
Right.
used. There,
Yes.
there's that's that local level connect back to,
Right.
the broader view of the entire EMS system.
Mm-hmm.
I guess we would work back to our medical directors,
Yeah.
and then we'll talk about all the specialties that
Yes.
then funnel into this.
Because the coordinators and supervisors got to go to somebody above them. You know what I mean?
Sometimes,
so,
yep.
And that's why we're medical directors.
I just think it's interesting of it's not, there is a team.
Yeah.
There is a team,
and that people don't see.
Yeah.
I mean, if you work across the system, you're going to run into all of us. And we've had a lot of them here on our podcast. I'm obviously out at Portage. I'm also at Western Reserve now. Spanner's our big CMO. He's the chief medical officer for EMSI. He's got his own, he works out of a Huja, has his own squads. Dr. Jordan Singer out in Elyria, big in the blood world, as well as buprenorphine and Narcan are some of his big projects.
But it's important to reference, like, his projects are then going to become system-wide.
Correct.
You know what I mean? Like, Singer's working out that way, but it's eventually going to make it to us down here at Portage and that kind of thing.
Yep. So we all, and Dara's at Ahuja, Dr. Consing joined me recently this year at Portage. So yeah, there's a big group of us that we all get together, and it's not just when we have a monthly meeting that we all get together, we talk about issues. If I have immediate needs, I've got my people that I go to, and even inside with that group, I'm like, and oftentimes it's going to be Jordan, it's going to be Dr. Consing, it's going to be Dr. Spanner, unless it's like a TAC med thing, and then it's going to be Dr. Dare. Like, we all have our own specialties kind of inside of the group. I'm more like the OneDose tech side.
Correct.
So if they've got an issue that, they come to me. But that's our core group, that we bounce ideas off each other, and we all kind of come together. And if we're making a big decision, we all speak our piece. We have a conversation. We talk about what the data shows and what we think works, and then we make a decision together. And it is our combined decision and all of our knowledge and experience that informs what kind of comes out of that group.
Right. Mm-hmm. That's what I think is interesting. Like I said, it's not your department. One department you're on is dealing with one doctor, but there's so much more behind that.
There's a team behind that. Yeah. It's often not just that one doctor's sole opinion. It's a composite.
I can't think of a single decision that I make independently. It's a group decision that we all make, that we all stand behind, and that's a good thing, right? We get
there's power in numbers.
Every side of it. Oh, I've got this experience that's probably not going to work for you, so I would do it this way, and that's why we do things this way. So,
well, just like we talked about the community hospitals having CMC, it's the same thing there, where it's such a large knowledge base that someone has, might know something more or read a study or what it happens to be. So
and we interface with those specialists. Correct. So we have trauma specialists that we'll talk to. We've got neonatologists that we talk to who've been on this fine program of ours.
Yes, absolutely.
We've got our stroke colleagues as well. So we can all reach out to them, and then we just have regular, I won't say regular, but critical care doctors that are internal medicine, critical care, pulmonary care, that inform how we provide care out with ventilators or intubation or in that realm of the critical care area that obviously I'm good at as an emergency medicine doctor, but they're going to know things that I don't know. And we have our cardiologists, and when it comes to cardiology care, STEMI activation, STEMI mimics, and inform the decisions we make, how they help us with protocol development. and then also help us with education, which is probably one of the bigger things that we as an institute do is educate and re-educate, both initial education and then continuing education through our providers.
From a man-hours perspective, for sure.
Yeah.
Absolutely. But even so, we talked about the EMS medical directors, but on EMS staff, we have pediatric specialists.
Yes.
So it's not an accident that some of the people come onto this program, right? They are part of our direct, not just a colleague we know in the hospital whose specialty this is.
Correct. Yeah.
They are paid by the institute to provide EMS feedback. So Dr. Stefano is a great example, right? He leads our cardiology charge. He's our tie back to HHVI. We've had Kelly Montgomery on, our stroke manager, right? She's a nurse.
Dr. Yaski?
Dr. Yaski. I was heading to Dr.
Amazing.
Yaski, right? So she's our Rainbow Babies and Children pediatrician that
There's also emergency medicine, which is also
also EMS.
Also
She's got
EMS.
EMS boarded as well.
Right.
So it's not just, we're lucky in that we have that third and fourth layer way back, but we have those people that can give us immediate feedback. We can get things tied off quickly, right? That work for us, not just with us.
Yeah.
Yeah, I guess that
protocol development.
into protocol development.
Yeah.
So at least one person here is qualified to talk about that, maybe two. But this is I don't know.
OneDose over here.
I don't know. Yeah, let's say it.
That's true.
So that does come up from time to time. Is where do these things come from? And there's in our area in the Northeast, kind of this Northeast Ohio. There is this regional EMS protocol. That regional EMS protocol was all of the kind of the big players in Northeast Ohio coming together and settling on pre-hospital topics. Right now, all of that was previous things that were already out there. So there was already a product that we took, and then we just tuned a little bit for everybody's needs. But that expands outside of the UH sphere is gigantic, but there are other hospital systems, the mecca of healthcare, right? Between university hospitals, we've got Cleveland Clinic, we've got Metro. In the protocol space, there's also Southwest, who gets represented, affiliate of ours, but they get represented on their own space there. We even have some representation from some other hospital systems that kind of surround us. They don't really participate, but they do give us some feedback. So even though they're not taking that protocol product and giving it to their people, the procedures and policies line up pretty well. So that's really nice. So we don't have this huge variance for the provider out in the world. So there's that group of doctors that get together. It's the voting members of that regional from that regional perspective is each hospital has a voting coordinator, which is almost always a paramedic. There's one nurse that's in that space, affiliated with the hospital system, and then there's a medical director, and then a backup to that medical director. Obviously, each system gets two votes, right? One coordinator, one doctor. Obviously, the doctor and the coordinator usually follow suit with each other when we're talking about topics, but nevertheless, so many other people and specialties join those meetings from all of the, we did a lot of overhaul on OB things this last year, and we had representation from all of the OB services at all three of those major hospitals, right? So we have people that compete in the healthcare space that are coming together for the betterment of EMS and the betterment of patients, which is huge in and of itself. So I can't say enough about that system. Then internally, we've got our own team, right? So the way this usually works is our meeting precedes the regional meeting. So we get together this arc of whatever the idea or whatever the thing is that we're looking to modify or change or add, or we get a consensus on our side, on the UH side of things, and then we've got our spokesperson that comes to this meeting, and so on behalf of all of the doctors at UH, this is where we're at with this topic, right?
Well, even I'll say that it probably should have been brought earlier, is like even in that subdivision, there are certain subspecialties, and OB comes to mind, where they even have their own internal panel in which they discuss, and then that panel provides, this is our opinion amongst all of our voting members, to say this is UHOB's opinion to EMS and what our recommendations are. We can have conversations about this, but this is what it is. So
this is what we are going to represent as best practice.
Correct.
For this, for our area and for our needs and our resources and whatnot. So there's a lot that balloons a lot, and then subsequently those products are then refined in the protocol and the policies and procedures, and then pushed out through each of the individual hospitals, kind of to their individual departments, right? So the stuff that gets pushed out through us is almost identical to what gets pushed out to the clinic. Is almost so it's all very close. So if you're a clinic guy and we wind up on a scene together, we are doing the same things, right? With the same colored boxes in the same order. So that's, again, huge for the providers and ultimately the patients, right?
And our protocols developed such that we want you operating, and that's kind of across the whole thing. As a paramedic, I want you doing top of your cert. Right? I want you to do everything you can possibly do. I'm not going to handcuff you in any way. I want you to make the decisions in the field to provide the best care you can for the best patient. You don't need to call me to say, Mother, may I do something to save my patient's life? It should be, yes, just go do what you need to do for your patient's life. And that's how our protocol's written. There's only very few, literally less than 5 things, I think, in the whole protocol that you would need to even call for med control before you do something, but those are based upon the safety issues. We want to make sure that what you're doing is going to be safe for the patient, because it can cause detrimental damage before you do that. And we're not talking about it's not a cardioversion. It's around specific drugs that can cause huge issues that we want to make sure we avoid.
Yes, of course. There's even one thing comes to mind, because I think it's the thing that I most often get accosted about when it comes to why is it red boxed, right? And we carry multiple beta blockers in the drug
AFib's
box.
the one you're.
What's that?
AFib is the
question. Not necessarily AFib, just why are the beta blockers? Why are the beta blockers red boxed? Meaning we have to call. And again, that it's really a safety thing to make sure you're using the right beta blocker in the right space. A beta blocker isn't necessarily a beta blocker, isn't necessarily a beta blocker. There's subtle differences, There's nuance to it, which can potentially be harmful if incorrectly applied. Or going to lessons learned, which is kind of why we're here, right? But we coach. We coach the providers. This doesn't have to be this big, long, Mother, may I do this thing. You're literally just cross-checking that with a physician. It needs to be a 15-second conversation. Hey, it's Scott. I got this patient. The blood pressure's at this. I'm using this beta blocker for this reason on this patient at this dose. You good? We're good. Have a nice day, right? That's all it needs to be. It's like you can just front load that conversation. It doesn't have to be, this whole story. I'm doing this for this reason. I've got the right one in my hand. That's that's the only it's a sales pitch. That's all it is.
Yeah. We'll check that with EMAC.
And you'll be able to check that with EMAC, right?
I want to give 5 milligrams of metoprolol for this reason. Patients on metoprolol at home, they're not on these medications. Correct. They've had this in the past. Their blood pressure is this. We want to hear all those things to make sure it's safe, so that way.
Right.
Because you tell me, I've got an unstable AFibber whose blood pressure's 80 over palp, and I want to give metoprolol, then that's not the right answer.
No, this is not the right answer. How we choose to put the protocol out and manage the protocol has changed drastically in the last year.
Literally last year.
Literally a last year and a quarter. Yeah. It's been at this point. And the decision support that has come with that. Let's talk about the tool we have chosen and then, as to your point earlier, has kind of become your baby. You answered the cold call when most all of us ignored it, and set us on a trajectory for what is honestly a really amazing partnership with some people that are trying to do some cool ass things and safe things in our space to make patient care better.
Yeah, so we chose OneDose after literally just a cold call. They cold called Caleb, wanted to sell him a cot, and he thought it was pretty cool and passed it on to us. I looked at it and thought it was novel in how they were really selling as a clinical decision support tool from the pre-hospital space. And I wouldn't even just say pre-hospital. We've now transformed that into the out-of-hospital care space, whether that's before you get to the hospital, interfacility transports, and that's both BLS, ALS, and critical care. We've kind of really grown with them. They impressed us from the standpoint of how we are able to manage those PDFs. So
we are able to manage. That's huge.
It's huge that we can go in there and something changes as quick as we make a decision to change it, and it's changed. It can be uploaded into OneDose, and instantaneously it's in everybody's pockets. That has been huge for us, and something that we couldn't even do with our own tools before we partnered with OneDose.
Over a year ago, right?
Yeah.
I use our last very subtle change. There was a state scope tweak, call it that, right, which allowed advanced EMTs to give IV Zofran, which wasn't previously a thing. That finally changed after years and years of, come on, you're killing me here, Smalls, right? And the meeting went like this. Does anybody object to this? No. I went back, made the changes on the computer, and had that pushed out, and it was changing real time in that, in the provider's pocket. We followed that up with a notification, which is a huge tool within OneDose, like, hey y'all, we just changed this. So what would have taken probably days and 12 hands would have had to, the real number is 3, but I'm over exaggerating a little. A lot of people would have had to touch it to get that disseminated, not including education, right? To get that disseminated, nobody would have read the emails and stuff like that. Literally was a cumulative from decision time to live was a 12-minute process.
And I think it'd probably be even longer than that if we were to make a change like that. And we are making changes like that we're more strategically rolling out, which our planning process is taking 2 months before we're getting into people's hands.
Yeah.
So we have to go through, we've made a decision, we're going to make this change. How are we then going to educate on it? And then we have to talk about, well, it's going to take a month to make sure that we've got people in front of providers to talk about what the change is doing. Now we can instantaneously, and that's why we've harped on from an institute standpoint that we want you to have OneDose access, so that way you get these critical notifications, because critical things can change. And we're bringing in more automated notifications to that, hoping to update providers on real time of what the statuses of hospitals are. So if a hospital goes on diversion, you will get a notification in your pocket in your OneDose to say, oh, that hospital's on diversion for whatever reason, right? Pipes froze, lost power, we flooded. That can be real time from that standpoint. So that's a notification thing that we didn't have. And even today, AJ sent out an email that went to all the chiefs and coordinators, but that information, not necessarily valid to the line worker, but there is times that we need to get information out that's valid to that line person that we need to have everyone get. And we didn't until OneDose have a system to easily communicate all the way down to everyone on the team to know what's happening.
Well, then did I print it and change page 47 to the new page 47? No.
Yeah.
Well, yeah, that goes into another.
It's funny. That got brought up the other day at my place. They're like, "Oh, can we still print the PDFs and update them?" And it's like, we'll do what we can, but it's going to be tough. You know what I mean? Because if we're doing live changes, I mean, everything's going to be. Yeah. But there's still folks that still want.
They do want the book.
Yeah. But
and we give them.
And it's available.
It's available.
We give them that product, right?
Yeah,
they can press print on it, right?
Yep.
But I can't guarantee that's going to be the most up-to-date information that we can guarantee you in your OneDose app that it is going to be
the most up-to-date.
Yeah, it's usually, since we've instituted this and taken a lot of the work and the hyperlinks and stuff of that PDF document out, that's only lagging sometimes a day or two behind the live update in
Right.
OneDose.
Yep.
So it's not
Not like it used to be.
it's not that impactful,
Yeah.
but it's certainly not like it used to be, right?
Yeah.
How many links were there?
I don't want to talk about it. I think the largest change we had was 2,700.
Oh man.
And he and I I'll grouse about this publicly. When we would add pages, Jordan Singer, when we would add pages, it would break most of the links, and we found it was actually easier to just wipe it and re-hyperlink the whole thing.
Really?
Yeah, that because at least you know they're going to the right place, rather than trying to
Just fix the
make
broken
sure that it's
yeah.
connected. But things might work connected both ways,
Right.
and that's where it really, all that's gone now.
Right.
So again, that's why we're looking at
Yeah.
maybe at the most it's a day behind because I'm waiting for the website administrator just to post the version that we sent them.
Yeah.
Right? The links aren't there if you want to if you want to navigate quickly, you do that in the app, and then if you want a printable document,
Yeah.
that's where the PDF lives. So let's talk about some of those decision support tools based in OneDose, because it's not just a protocol slide sorter.
It's not. So one of the things that really was the add-on to us and was doing MedMath. MedMath's hard. I don't care who you are, MedMath's hard. Doesn't care if you're a nurse, paramedic, doc, MedMath is hard. I use OneDose in my own practice in the emergency department to help with MedMath. So MedMath was the big sell for us that we launched immediately. Is you put the patient's weight in. OneDose is smart enough that it knows what concentration of med you have in the box. So it does all the MedMath for you. Like, I got this weight, I got this concentration, this is the total med you're going to give the patient. Say it's
Volume,
5 milligrams plus the volume that you're going to draw up into
That's
your
The
syringe.
ML is the thing.
Yeah.
I love the ML.
Yeah, it's the division that
Yeah.
that everybody fails on.
Correct.
Most everybody can multiply. It's division that that repetitively gets all of us.
Yeah.
Decimals are terrible.
Well, unless it's like 1 milligram per ml,
Yeah,
or if
right.
it's a 10 or 100, sure, that math's easy. Oh, I've got 4 milligrams and 5 mLs. Like, who did that?
Why?
Which pharmacist wanted to hate everybody?
Hate everybody, yeah.
So it does all that med math for you. That was a big help and big safety thing for us that we can give an extra tool to the pre-hospital space, inter-facility space, to make sure you're giving the right amount of medication
Yeah.
to your patient. So med math was a big thing. As of this recording, we're launching EMS calculators. So we, in concert with OneDose, developed, hey, we'd be great if we could do other things besides MedMath. We want to be able to do APGAR scoring.
APGARs and
Cincy's
shock
in there,
index,
GCS shock
shock
index.
index,
Yeah. One thing for me that I always have to look up is pediatric Glasgow coma scale.
Yeah.
You've got a baby that coos at you. Well, what's their GCS? I don't know off the top of my head. So that
Yeah, you don't
tool's
do it
in
enough,
there.
right?
Yeah, exactly. It's not maintenance fluid calculators. If you're doing interfacility transports, what rate are we going to run this maintenance at? Or are we going to do 2 times maintenance? RAS scales. You've got nurses that work in the emergency department and ICU that don't know how to do RAS off the top of their head. Well, now we've got a calculator that helps you do that. Rule of 9, Van score, those are all kind of built into the app to help you guys make those decisions and do those on-the-fly calculations as one of the extra tools. We also added checklists this year, so something we're building out because we didn't have the space to do that initially in the protocol.
Yeah.
Jordan Singer was kind of big on this, so checklists for innovation
Innovation,
checklists.
RSI, yep.
Yep. So, hey, we're going to do all these things. We're going to check it off. And now we can timestamp to that, and you can give proof to your medical director, yeah, I checked all these things. Here's my timestamps. And when I checked those things off, and it was to make it a safer
Event, yeah.
to
Yeah.
do a high-risk activity.
Yeah.
Yeah.
And now we've got post-ROS checklists. So we're
Right.
putting stickers now on the sides of all of
Our-
every Lucas device we come across, whether it's inside university hospitals or you're a med controller, you're not even one. We're going to put a sticker on there like, hey, great, you got ROSC.
Now optimize.
Yeah, this is the time that they're going to rearrest. Let's make sure that they don't rearrest. Let's make this
Do
safe
these things,
transitions.
yeah.
So we're developing these checklists now to find other high-risk areas that we need to make sure we kind of slow down. And they do this in the aviation industry, which is the safest way to travel. They're going to run their checklist. Hey, all right, we got ROSC. Let's run our checklist. Make sure that we're safe to move on to the next stage of care.
Yeah.
Yeah, very nice.
Other things that are going to be coming out from OneDose is CPR Assist. So you two have had personal experience with doing CPR Assist. So there's a lot of apps out there that I even had one on my phone that I didn't have a way to keep us in tune. Like, okay, where am I at in the cycle of giving medications, giving verbal and auditory clues for a ventilated patient. Oh, it's time to do a pulse check. Typically, I'm lucky in the emergency department. I've got someone that's their whole job. But if I'm shorthanded and I need someone else to do it, now I've got a tool in my pocket that can help with that. You guys are already short-staffed in the pre-hospital space.
I think once we get the training along the board, everybody on board, that's going to be a huge help. Just keeping the times, you know what I mean, and when things are going to happen. We all know how it goes. Oh, 3 to 5 minutes. It's 6, 7, 8, 9, 10 minutes now.
Yeah.
You know what I mean?
Yeah, we get
gonna
distracted.
It'll be huge.
Larry in the hospital uses RQI for their reassessment.
Yeah.
So it's an American Heart, kind of reassesses. Well, they have a computer, and you have to bag.
Mm-hmm.
That is uncomfortably slow.
Yeah.
Every 6 seconds is a lot longer
100%.
You know what I mean?
Yeah.
When you're watching that screen and you're like, oh, I want to squeeze that bag again.
Well,
you know?
especially for those of us that were taught in a time where more was better.
Squeeze hard as you can, faster.
Yeah, harder and faster was better as it was taught to us, right? It's first it was hyperventilate, then it was you don't overventilate, it's hyperoxygenate.
Right.
Okay, come on. Once every 6 seconds is an exorbitantly long
It is.
time. Right?
Like so, when that computer was staring at
Yeah.
you, and you had, I'm doing it.
Yeah.
It was like uncomfortably slow.
Yeah.
So that's nice to have that.
It just helps with the timing of everything.
It does.
Yeah.
Peek into the future that we don't have right now, but it's probably coming down the pipe in EMS care is, and I know that Caleb loves his VT Select.
No, that's
but there's a big conversation in the EMS pre-hospital, out-of-hospital space about what type of pressure are we giving, what type of volume are we giving, and we're overventilating, overpressuring most of our patients.
Are you suggesting that humans are bad at ventilating other humans?
Yes, I am.
Oh, okay. Well, yeah, that is
There are a lot
been well established, right?
So there are a lot of companies out there that are trying to solve for that problem. They're trying to develop devices
Tools
that
like this,
make us better ventilators.
Yeah.
Unless, of course, you're lucky enough to have a ventilator.
And I think that's, and if you're interested in that topic, well, our vent guru, our RT paramedic, we did a whole bit.
That was great. That was great series.
No, I had a blast doing that talk with him. Obviously near and dear to me, but nevertheless.
The one last thing that I want to talk about with OneDose and what we're doing is we knew that there's a problem with wrong medication to the wrong patient, right? OneDose realized that, and there are other people out in the space. Mac was the hey, we know that we have a problem in giving the wrong medication to the wrong patient. We solved that problem in the hospital space years ago. Somehow we didn't solve it in the pre-hospital space. So working with them, we identified that this was a problem for us, and we had 2 incidents over the last year that I can really think of that caused concern for us that we partnered with them. We did beta testing for their EMAC, their medication scanning.
Yep.
Slicker than snot.
Yep.
It's better than what we have in the hospital by every stretch of the imagination.
That's it. It doesn't require any special hardware.
Correct.
My EMAC scanner is
Your phone.
right here.
Yeah.
So to that verification, we're talking about making sure you're giving the right beta blocker. Now, that's metoprolol, but I've got a impartial device that doesn't get tired at 3 o'clock in the morning to verify, you're giving the right medication. It then gives you a visual representation of what it gives you a recommendation on which syringe to use, and then a visual representation on that syringe of how much fluid, how much mLs you're going to pull up into that syringe to then give to the patient.
Yeah,
so
that's huge.
Huge safety benefit from us, and we're first in the country to
What I
use
thought
that
was interesting
technology.
too is, again, it expects our concentrations.
Yes.
But even if something happens
Out of concentration.
and it gets out of concentration, it warns you.
Yep.
And if you're sure that's the right, you scanned it,
It'll do the math.
It
Yeah,
recalculates
right.
for you. I mean, that's,
Yeah.
that was impressive.
I'm here to help. Which is not a problem that with our pharmacy
Correct.
involvement. Honestly, I don't know of a case like that where we've had an incorrect concentration.
Provided,
provided.
But we tried very hard not to mix up those concentrations in
Oh,
the
my
box, and
goodness.
we'd much rather put a different med in the box than script
Then
concentrations.
multiple concentrations. Yeah.
So then coming down the future from tools is they've integrated artificial intelligence built upon our own protocol that you can ask its questions. And honestly, by the time this airs, it'll probably be a
likely
feature
be out, yeah.
that you guys can all use.
Yeah, and then again, that's specific to our. So you're not asking it of a generic AI bot that's going out and, parsing the web for. It is giving you a targeted answer based on your protocol.
Mm-hmm.
Again, that's
and
huge.
giving you a link to be like, here is the protocol.
Here is the
You're gonna look at-
protocol.
You can look at the PDF.
Here's the calculator.
And
Here's
look at
all
the
the
calculator,
all the things to go with it. It's a very interesting technology. How it'll be utilized, I think, is going to vary a lot, provider to provider. I think some probably younger are going to lean more on it. Some of us will probably use it more for fringe stuff. At least that's how I have, kind of like, I know this was written for somewhere, but I don't want to spend 10 minutes looking for it, right? That's probably where I'm personally going to see the use. The other thing that they're doing is allowing us some basically a document center where we can put in other common reference things and be able to parse that by AI as well and not confuse it with things that everybody needs access to, like the ERG, the emergency response guide, or the operator's manual for your cardiac defibrillator, or so the things like what's that red blinky light on the side of my power load mean at 3 o'clock in the morning? You can just go into the knowledge center and go right to that answer, right? You don't have to go back to the station and download it from Stryker or whomever you're using, and go through it yourself. It's just going to give you that real time. So I think that's going to be huge too.
So I don't need the 800 books that they sent me with my Back 35.
I
have stacks.
They do like they
like paper. Yeah.
In every language.
Yeah.
In every language, it's like there's
Is that a regulatory?
It sure is.
I'm sure it is.
I'm sure it is.
Yeah, the modem book was this big, and I needed 3 pages.
3 pages of it, right? Yeah.
And the other thing that
One
Windows
page is hieroglyphs.
one thing that Windows does that we've I just forgot about until right now is contacts.
Oh my goodness!
Yes, that is a big
has
deal.
been a huge thing, and we had an issue with contacts even just 2 years ago that we had an ambulance heading in the wrong direction to a site that didn't have what we needed.
Yeah,
so we had to
correct
turn
resources.
them around to send them away. So
Coming down the pipe. Say I search UH Portage and they're on diversion. If I search that in context, will it notify me that, hey, they're on diversion?
Not yet.
see what I can do.
That's
I don't
going
know.
to go.
Just
They'd have to parse Javari.
I don't know. It was just
They're already getting a notification though.
kind of off topic.
Yeah, but they're going to have.
It was in
it's gonna have
notifications,
to-
but I didn't know if, say you missed it or something, you didn't look at it, but you search Portage. Hey,
You said contacts, but again, somebody hasn't used it. You can search by need, right? So
Correct.
everything is flagged.
Yeah.
Well, you
So
can search by. I need contact information from my own med director. Med directors are in there.
in there, yep.
Our phone numbers are in there if you need to call me. ERs are in there, and then what services that they provide are broken down.
And they're tagged,
and
right?
They're tagged,
So
so you can.
you can put multiple tags on
Yep.
if you need some wild concoction of I need a trauma center with OB services and
Yeah.
toe reimplantation, right? And then here's your options.
Yeah. I just got a call the
that
other
page
day.
would be blank, by the way.
Totally. I just got a call the other day. Somebody was like, hey, can I get a med director's number? I said, hey, just go into OneDose. Let me find it. And it worked great. So
Yeah,
there it is.
that was the try harder
Yeah,
conversation.
it worked.
OneDose has become our single platform for disseminating information, providing information to everyone that needs to have it. And in fact, right now, one of the things we're doing behind the scenes is even trying to onboard our dispatch centers.
Yep.
So that way we can notify dispatch centers of things that are happening inside of the healthcare system. Hey, hospital's flooded. They're going to be on diversion. So don't send there. Sometimes they're going to know that, but there's going to be sometimes people are really good about notifying local resources about what's going on, but not notifying like a whole system of what's going on, right? We're bad even inside of UH for that. There's an incident that recently happened that affected one of our hospitals that didn't get disseminated out by normal means, it only got disseminated out through
us,
OneDose,
through the
us.
institute,
Yeah.
through the
So, yeah, OneDose has become a huge tool for us because it's one place that unifies across multiple agencies and that don't even use the same software, right? I mean, great. I can send a email out through, if you use Health EMS, if you use ESO, if you use EMS charts, if you use IMS, but those are the main software packages that you use for PCRs, but I've got no way to just in one place get to everyone's inbox the information that we need to do. And we're not spamming you, we're trying to give you the information you only need.